Thank you for having us to speak with you today about stroke. Stroke is a very important topic to tackle because it is both common and devastating, as well as potentially fatal in nature. Stroke care is certainly evolving with treatments becoming time dependent. So, as medical professionals, we do really owe it to our patients to increase our knowledge and learn to be as effective as we can. Before we get started, we would really like to give a shout out to the American Heart American Stroke Association. They have an excellent presentation called Stroke Training for EMS Professionals that really served as the inspiration and outline of our presentation and as a source of excellent information. We adapted much of that to make it appropriate for the area in which we work. The objectives today are hopefully by the end of this course, the learner will be able to better understand acute stroke clinical presentation and management, allowing them to deliver more efficient and safer stroke patient care, understand the various levels of stroke center designation, identify two types of stroke with common presenting symptoms, and to be able to identify less common stroke symptoms. Just a brief introduction, a little bit about us. My name is Nikki Miskell. I am a stroke certified registered nurse. I've been a nurse since 2014. My first job out of nursing school was actually in a hospital on a stroke unit where I really fell in love with this patient population. I moved on from that to the emergency department where I remained a stroke champion, just loving to work with this patient population, eventually becoming the stroke program coordinator at University of Maryland, Capital Region Health, which is where I'm coming from for you today. My colleague Amy will introduce herself.
Hi everyone, my name is Amy Swoboda. I'm currently the stroke program coordinator at MedStar Southern Maryland Hospital Center. I started as a stroke neurosurgery nurse at MedStar Washington Hospital Center after graduating from nursing school in 2015. I found that I loved caring for stroke patients, especially post-neurosurgical procedures. In 2017, I transitioned to Anne Arundel Medical Center as an observation unit nurse and quickly became a stroke champion and an active member of the hospital stroke committee. In 2020, I became the clinical educator of the neurocare unit and helped train new nurses on stroke patient care. In November 2023, I accepted the position of stroke program coordinator at MedStar Southern Maryland Hospital, where I'm helping to establish our stroke program. I'm passionate about providing the best care for our stroke patients.
Excellent. Thanks, Amy. All right, well, let's get started. I think it's important to really start with the bottom line up front. Why do we care? Why are we here today? So number one, stroke is prevalent and devastating. Number two, the overall goal of stroke care is really to minimize acute brain injury and maximize patient recovery. And three, while treatments do exist, they are limited and time dependent. In fact, as EMS providers, you're probably very familiar with the idea that treatments may be dependent upon the actual facility, right? So certain stroke centers may be able to offer particular interventions to our patients. Treatments must be administered within a specific time period after the onset of stroke, so that time is brain is very important. The rapid identification, evaluation, and treatment is directly related to patient outcomes. And EMS is a crucial link in the stroke chain of survival. You see the stroke chain of survival listed there in the bottom right-hand corner. And really this is talking about starting with the recognition of stroke signs and symptoms and activation of EMS. EMS then is a large part of the chain of survival when it becomes time for dispatch and in-field assessment. EMS will then transport the patient to the particular stroke center that patient needs to go to, as well as provide a pre-hospital notification. And then it becomes the stroke center's responsibility to perform rapid diagnosis and treatment of the stroke patient. Just briefly, as we talk about that stroke chain of survival and the importance of EMS taking patients to the proper locations, we did want to take a moment to discuss hospital designations. Within the state of Maryland, there are currently 4 stroke center levels available for certification. All of these stroke centers have made a commitment to provide evidence-based stroke care to their stroke and TIA patient population. And within the state of Maryland, we all carry a MIMS, or Maryland Institute of Emergency Medical Services Systems designation. These hospital stroke centers range from acute stroke ready all the way up through comprehensive, and the level of stroke center that a hospital is designated as is really going to depend on what types of services they can offer their stroke patients and how many hours of day, days of the week, weeks of the year that service is offered. So, for example, all stroke centers are going to be able to initially evaluate the emergent potential stroke patient and offer acute treatment such as IV thrombolytics, which is a strong clot-busting medication. However, a center like Acute Stroke Ready would then have to transfer that patient out in order to continue with that patient's care. Comprehensive stroke centers on the other end of the spectrum are going to be able to manage all manner of complex stroke patients. Not only will they be able to evaluate the initial emergent patient by administering IV thrombolytics, but they're also going to be able to offer 24/7 neuroendovascular therapy such as thrombectomy, 24/7 neuroscience ICUs, and 24/7 neurosurgery. A comprehensive stroke center will be able to manage a patient with an aneurysmal subarachnoid hemorrhage, large intracranial hemorrhages, and malignant cerebral edema. This slide just talks a little bit more, just kind of shows you a little bit more about what each stroke center offers. So you can see here that Acute Stroke Readies are going to be typically rural, right? They're going to be able to do that initial assessment, that initial CT. They'll provide initial treatment to the patient with that 24/7 thrombolysis capability, and then the patient will have to move on. As the stroke center becomes higher and higher designated from primary stroke center, thrombectomy capable, and comprehensive, you start to see that more services and equipment is available. All right, so why do we care about stroke? As we mentioned earlier, stroke is common and devastating. We see that it's currently listed as the number 5 cause of death in the United States and a leading cause of permanent disability. Nearly 800,000 people each year are going to suffer a stroke, and about every 4 minutes, someone is going to die of a stroke. And actually, where we work in Prince George's County, currently stroke is listed as the number 4 cause of death in both the state and the county. It was number 3 prior to COVID. This data goes up through, I believe, 2022. So it will be interesting to see as the data, gets updated if it goes back up to number 3. And then this point listed down here at the bottom is really a big driver of emergent stroke care. So it says 1.9 million neurons per minute are at risk in an untreated stroke. So when we talk about time is brain, this is time is brain quantified. So we know that when we talk about this 1.9 million neurons per minute, that faster treatment then results in better treatment. So, really we can break this out not only to 1.9 million neurons per minute in an untreated stroke, but also weeks and years of aging. So really this ends up translating to an estimated 3.1 weeks of aging for each passing minute. We've seen numbers ranging up to 36 years by the end of a completed stroke. So we really do want to get stroke care moving faster. While work over the last couple of decades has focused significantly on lowering door-to-needle times, pre-hospital delays are currently still the biggest barrier to timely treatment. So what happens in the pre-hospital setting is definitely of the utmost importance. All right, so what's a stroke? A stroke is a brain injury that occurs when blood flow to the brain is interrupted. This can either be due to a blocked blood vessel, like in ischemic stroke, or a ruptured blood vessel, like in hemorrhagic stroke. Blood carries oxygen and nutrients that our brain cells need in order to survive. So the part of the brain that can't get this oxygen and nutrients begins to die. The symptoms that we notice as clinicians are the result of whichever area of the brain is affected by this interruption in blood flow. Ischemic stroke is far and away the most common type of stroke. This is going to account for approximately 87% of all strokes nationwide and occurs when a blood vessel to or in the brain becomes severely narrowed or blocked. These blockages could be embolic, meaning that a clot develops somewhere else in the body and travels to the brain, or thrombotic, where a clot develops in an artery inside the brain, sort of at the site of that occlusion. Causes of ischemic stroke can include diabetes, high blood pressure, high cholesterol, atrial fibrillation, and cardiovascular disease. I do want to take a moment to mention here TIA. TIA stands for transient ischemic attack. This is very similar to ischemic stroke in that it is caused by a sudden blockage of a blood vessel inside the brain. However, in TIA, that blockage is brief. So a patient will briefly present with symptoms, the blockage will resolve, those symptoms will disappear, and there will be no permanent damage to the brain. However, TIA is extremely important as it serves as a serious warning sign that a stroke may be on the way. So we want to take TIAs very seriously. Hemorrhagic stroke, less common but arguably more deadly, occurs when a blood vessel in the brain ruptures. So blood leaks out into the brain tissue, increasing pressure and leading to swelling. There are a couple different kinds of hemorrhagic stroke. So you could have an intracerebral hemorrhage or a subarachnoid hemorrhage, and that's just going to depend on the location where the hemorrhage has occurred. Causes of hemorrhagic stroke could include things like ruptured aneurysms, chronically high blood pressure, blood thinners such as Eliquis, Pradaxa, Coumadin, illicit drug use such as cocaine, or underlying medical conditions such as amyloid angiopathy. It is important for us to take just a brief moment to discuss neurovascular anatomy. We'll try not to get too in the weeds here, but there are two main ways that blood is supplied to the brain. We talk about the anterior circulation and the posterior circulation. The anterior circulation is going to start with our internal carotid arteries, branching off to the middle cerebral arteries, anterior cerebral arteries, and others. This is going to supply our frontal lobes, parietal lobes, temporal lobes, and some deeper structures within the brain. The posterior circulation is going to be formed through our vertebral arteries, coming together and becoming the basilar artery, going up through the brain stem and branching off into the posterior cerebral arteries and others. This is going to supply our brainstem, cerebellum, occipital lobe, part of the temporal lobes, and some deeper structures there as well. And then we have this really important structure called the circle of Willis, which actually connects the anterior and posterior circulation, helping to provide protection through collateral flow. And as you can see here, and actually in another slide I'm going to advance to shortly, different areas of our brain have different functions. And the stroke symptoms that we identify as clinicians are going to be due to interruption of blood flow to a particular area of the brain. So for example, if blood supply has been interrupted to an area of the brain that controls our ability to speak, then as clinicians, we're going to notice that patients are going to have difficulty producing language. And having this basic understanding of the way the brain is perfused, can kind of help us to identify where a patient may be suffering a blockage. The other thing that's important to note here, right, as we start talking about large vessel occlusions, is that you can understand that if you see a small artery blocked, then only the small area that artery supplies blood to will actually be affected. However, if one of these large vessels, like the internal carotids, middle cerebral, or basilar artery are occluded, then a much larger area of the brain will be affected. All right, now that we know what a stroke is and how the brain is perfused, let's talk a little bit about identification. We typically use BFAST to help us recognize stroke symptoms. This is going to sort of be similar to your Cincinnati Stroke Scale as well as the posterior cerebellar assessment. So for BFAST, we like to say BFAST to recognize a stroke. B is for balance, sudden changes in balance, coordination, or dizziness. E for eyes, sudden visual changes or gaze preference. F is for face, facial asymmetry. A for arms, arm or leg weakness or numbness. It's typically unilateral, meaning one-sided. S is for speech. So difficulty either producing speech, difficulty understanding speech or language comprehension, or difficulty with slurred speech. And then, of course, T is for time. Time is brain. So what you are seeing here with the FAS are going to be the more common sort of classic stroke symptoms. The B and the E were added some years ago to sort of give us a little nod to those less common stroke symptoms that occur in the posterior circulation. So the dizziness, coordination, and vision changes are going to sort of be with those posterior circulation symptoms there. So those were added to the FAST acronym to help us recognize stroke more easily. I do want to mention here that while we can't truly tell the difference between an ischemic stroke and a hemorrhagic stroke in the field without neuroimaging, it's not uncommon for hemorrhagic stroke patients to have additional symptoms like severe headache, nausea, vomiting. These patients may also experience seizures, which you may see. When we see a characteristic group of symptoms that consistently occur together, we actually call this a syndrome. So these groups of symptoms can tip us off about where a patient may be having a blocked vessel. So I'm going to take a moment to tell you a little bit about these large vessel occlusion syndromes, which many of you have probably seen in the field. A great example, the most common, would be this middle cerebral artery syndrome. So if a patient, first, actually, let me tell you, dominant and non-dominant. The dominant hemisphere of the brain is going to be the one that controls speech. In the vast majority of patients, this will be the left side, although there are some who it's the right side of the brain. Non-dominant is, of course, the side that doesn't control speech. So if a patient were suffering a middle cerebral artery syndrome, in a left middle cerebral artery syndrome, you would notice the patient would have aphasia, contralateral homonymous hemianopsia, which is just a fancy medical term for a vision issue where half of the field of vision has gone out. Contralateral motor and sensory loss of the face, upper extremity, and lower extremities, with the upper extremity weakness being greater than lower extremity, and ipsilateral or same-sided gaze deviation. So these would be patterns of symptoms that we would notice for patients suffering a middle cerebral artery stroke. And this is sort of where our EMS stroke identification and severity tools come into play. So I hope many of you on this call are going to be familiar with our identification and severity tools. There are many. I believe that the Prince George's Fire Department is currently using the Cincinnati Pre-Hospital Stroke Scale for identification, which is a 3-item scale evaluating facial droop, arm drift, and speech. Couple of things to note now that you guys are familiar with neuroanatomy is that the Cincinnati Pre-Hospital Scale heavily favors anterior circulation stroke. So you're going to notice it doesn't take into account dizziness or visual changes. So that's really where that BFAST came into play, as well as your posterior cerebellar assessment. The BFAST, as we mentioned before, is that 5-item scale, which includes the balance, the vision, facial droop, arm or leg weakness or numbness, helping us to decrease missed posterior circulation stroke cases. And of course, there are others, the LAPSS, MENS, or FAST. Once a potential stroke is identified, then of course we move on to the severity tools to see, do we think potentially that this stroke is severe enough the patient may be suffering large vessel occlusion and need to go to a specialty stroke center? I believe that this fire department is currently using LAMS, which is a 3-item scale evaluating facial droop, arm drift, and grip strength, looking at how severe is the presentation of those symptoms, right? And helps us to quantify these neurologic assessments. Helps us to quantify the neurologic deficits. A couple of things to note here. There are some pitfalls with stroke evaluation tools. They are not diagnostic. So when these tools are positive, yes, they have a high rate of sensitivity, but a patient can have a negative field tool and still be suffering from an acute stroke. So it's worth mentioning that there's actually no such thing as a rule-out stroke in the field. And severity scales such as LAMS and FAST-ED, of course, as you're all familiar with, are very helpful in helping us identify those patients possibly suffering from large vessel occlusion who should be evaluated at a thrombectomy-capable stroke center or comprehensive stroke center, of course, following your protocols for bypass.
Okay, so for EMS management, time last known well is the utmost important when considering eligibility for stroke treatments. We want to definitely indicate here that symptom onset or symptom discovery may not be the same thing as time last known well. So for example, if someone was with the patient when the stroke symptoms occurred, the last known well time and symptom onset would be equivalent. However, commonly what we see are people going to bed, they're last seen normal before they go to bed, and they wake up with stroke symptoms. In this scenario, time last known well and symptom onset or discovery are two very different times. So it's very important to indicate the time last known well or last seen normal as a part of your handoff to the hospital staff. As you all know, finger stick blood glucose is very important in any suspected stroke patients, as hypoglycemia is a very sensitive mimic for stroke. Medication lists are extremely helpful, especially focusing upon those medications that are blood thinners, such as warfarin, Coumadin, Eliquis, etc., as these are contraindications for thrombolytics. Hospital pre-notification, again, is very important to ensure that staff at the hospital are aware and readying themselves for an impending stroke patient. Lastly, a contact number for family or caregivers or the person on the scene is very helpful for the hospital to ensure that we have someone to contact and confirm any relevant medical history that may preclude them for getting time-sensitive thrombolytics. So for stroke center evaluation and treatment, the stroke team will meet the EMS team for a rapid exam to confirm the stroke symptoms that we all are seeing. Once that exam occurs, we move very swiftly to the CT suite to do acute stroke imaging. And what that means is that we first go and initiate what they call a dry or non-contrast head CT. And what this brain CT is doing is confirming, do we see any blood in the brain, which would be a major contraindication for thrombolytics. It does not usually confirm an acute ischemic stroke. What we'll then proceed with typically is advanced head imaging, such as a CT angiogram of the head and neck. And what this is looking for are, we're looking at the blood vessels of the brain and neck to see if there's any occlusion in those large vessels or small vessels, any dissections or stenosis in the arteries that could be causing these stroke symptoms. Then we may proceed with a CT perfusion, which is injecting contrast into the patient and seeing where that contrast is going in the brain. So what this helps us do is look at how blood flow is actually perfusing through the brain. And if there is a clot, we can actually see where that clot may be occurring and how likely that stroke is early enough to treat with thrombolytics or with mechanical thrombectomy. And these are the two acute stroke treatments we have to offer patients. So thrombolytics, also known as alteplase or tenecteplase, are your common clot busting medications. And it's very time sensitive again. So up to 4.5 hours from stroke onset or last known well. And again, those two time frames may be different. We are looking to give that thrombolytic within 4.5 hours of last known well. Now, what you may notice is that most hospitals have transitioned from alteplase or TPA to tenecteplase. They're essentially bioequivalents, which means that those two medications act the same way. And thrombolytics is the type of medication they are. The other option we can offer some patients are mechanical thrombectomy. And then there's hospitals in this area that specialize in thrombectomy, but understanding that your thrombectomy capable and comprehensive stroke centers are the areas that are the hospitals that can offer this type of treatment. Thrombectomy is mechanical clot retrieval that's occurring at these specialized stroke centers, and we can offer this treatment for anyone up to 24 hours of last seen normal or last known well time, as long as they are not contraindicated. And it's very important, again, for these acute stroke treatments when we indicate the time last known well and the windows of time that we can offer these medications, because, again, you are losing about 1.9 million neurons per minute, and that can greatly age the brain so that a completed stroke ages your brain roughly 36 years. And this is an example of what we see when we do neuroimaging. On the top left corner, you see non-contrast head CT. Typically, again, we're looking to see is there blood or no blood on the image. Blood within the brain tissue indicates likely hemorrhage, which would contraindicate that patient for a thrombolytic. Again, we typically do not see an acute ischemic stroke on this head CT. This is also time sensitive. We need to complete a non-contrast head CT within at least 20 minutes. And the other thing here that we may see on some acute ischemic strokes, especially if it's one of large vessels, is we may see a hyperdense artery sign, which gives us a hint that this person may be suffering from a large vessel occlusion. The CTA of the head and neck, the next image on the right, you see all these blood vessels there. And what we're looking here is to determine if there's a clot, is there a specific vessel that it may be lodged in. And so it's helpful for us to identify large vessel occlusions, but also other arterial issues or abnormalities, such as arterial dissection or vessel abnormalities such as arteriovenous malformation or AVM, or an aneurysm or outpouching of those blood vessels. The goal for us to complete the CTA of the head and neck is 20 minutes. CT perfusion, in the colored image that you see on below, again, helps to measure blood flow to different areas of the brain. And in this case here, if someone has had an acute ischemic stroke, we can actually see that infarcted tissue or non-salvageable dead area of the brain in purple here in this image. And we can potentially see the salvageable penumbra, or what that means is that tissue that if we took the clot out could actually be reperfused and saved. Again, this is a very important image for us to determine if the patient is eligible for mechanical thrombectomy. Typically, this imaging is most useful for patients who've had their last known well time greater than 6 hours. The other thing to mention here is that if that green and purple area are essentially the same, that suggests that the stroke has been completed and we cannot actually go in and remove the clot with any sort of benefit to the patient. Okay, now we're going to put it all together with some case studies. In this first case study, we had a 48-year-old female that presented with left-sided facial droop, left lower extremity and upper extremity weakness, dysarthria, and right-sided gaze preference that were noted upon wakening in the morning. She last felt normal the night before at 2100 before she went to bed. The history she had is hypertension and kidney cancer. EMS performed that Cincinnati pre-hospital screening scale and it was positive. The LAM score that they got was a 4, which is suggestive of a large vessel occlusion, anything 4 or greater. The blood sugar was 121, so that also ruled out that it wasn't hypoglycemia related. EMS made pre-hospital notification, including priority 1 stroke alert, with that last known well time indicated. The hospital stroke team was able to meet the ambulance at the ED ambulance entrance. They got the dry head CT or non-contrast head CT and advanced imaging with CTA and CTP completed within 17 minutes of arrival. So again, our goal is typically less than 20 minutes. And her hospital NIH stroke scale was a 10, and that indicates to us, the nursing staff and the ED and the physicians, an NIH stroke scale indicates severity of the stroke. So anything 4 or more typically indicates a moderately how to say this?
I would say moderate to large.
Moderate to large stroke. This is the non-contrast head CT. And what you're seeing here is that there's no white within the brain tissue, indicating that this patient was not a hemorrhage. Again, we would actually read this as negative or normal, which is very common in the setting of acute ischemic stroke, and that she wasn't necessarily contraindicated for thrombolytics as we did not see blood on this head CT. This is the CT angiogram of the head and neck, and that red arrow is demonstrating a clot in the right middle cerebral artery. So it's a right MCA occlusion that suggested that the patient was amenable for mechanical thrombectomy. To confirm if this patient was truly eligible for mechanical thrombectomy, we did CT perfusion. And this is a great example here that there was no infarcted core. So if you see on the left-hand side where the purple would show up, you don't see anything. And on the right-hand side, you see a large green area, which is the salvageable penumbra. So this patient actually was a fantastic candidate for endovascular thrombectomy, and she was flown out to a comprehensive stroke center where she received this procedure. Follow-up imaging for this patient. This is a MRI, a very sensitive brain scan that allows us to look more closely at the tissue of the brain. And so this person here, same woman, she was flown out to University of Maryland for a right M1 MCA clot extraction. Her door in, door out time at the primary stroke center was 102 minutes, which is 12 minutes greater than our goal time. So what you'll hear commonly in the stroke community is, what was our DIDO time, or door in, door out time? Our goal is to be less than 90 minutes for the patient to come to the original stroke center and be sent out to a comprehensive stroke center. Because again, time is brain. The faster we do this, the more likely positive outcomes will come to that patient. So when she left the University of Maryland, her NIH stroke scale was a 3, which is much more significantly lower than her original of 10. She's still not working, but has made significant progress. And what they were able to actually identify in her workup at the hospital was that her etiology for this stroke was a carotid web. And what that is, it's a very rare abnormality in the internal carotid artery, where it is exactly what it sounds like. There's a webbing there that actually predisposes the patient to more clots. And so that right M1 MCA occlusion was likely the cause from that. Case study number 2. 71-year-old female presented with right-sided facial droop, right upper extremity flaccid, and right lower extremity withdrawing to pain. So her right upper extremity was more severe in terms of its weakness than the right lower extremity. She was mute and had a left-sided gaze preference. She was found down by a family member in the bathroom at 7 o'clock in the morning. Patient was last felt normal the night before at 2300 before she went to bed. There was no significant past medical history, and at baseline, she was functionally independent. Her Cincinnati pre-hospital screening scale was positive. They weren't able to determine a LAM score, and this is something we wanted to definitely mention to you all, is that you can always perform a LAM score, because just because someone cannot perform it doesn't mean it's not going to give you a specific value. It's just that it might be higher than you would expect, and that's actually a good thing. EMS made pre-hospital notification, including a priority 1 stroke alert with that time last seen normal. The hospital stroke team was able to meet the patient and crew at the ambulance entrance. The CT, CTA, and CTP were completed within 32 minutes of arrival, so remember our goal is 20 minutes. And her hospital NIH stroke scale was 20, which really indicates a fairly severe stroke, which you can obviously see in the patient's presentation here. This is her CT of the head, and we do not see any obvious blood here. So that means she's not contraindicated for thrombolytics. Her CT angiogram showed what we believe to be is a left MCA occlusion. One thing I didn't mention here is when you're looking at imaging of the brain, what you typically see is on the right side of the image is actually the left side of the patient's brain, and vice versa. The left side of the image is the right side of the patient's brain. So what you're seeing here on the right side of the image is a left MCA occlusion. Here's the CT perfusion, and what you see is a small purple area of the core infarct. and on the right side, a large green penumbra. So this suggests that the patient had had, again, a large vessel occlusion that looked to be amenable to a mechanical thrombectomy. Follow-up MRI for that patient did demonstrate indeed a left MCA territory occlusion, but the patient actually ended up having no symptoms and is now completely back to normal. And at time of discharge, her NIH stroke scale was a 0. One thing we also didn't mention in this talk is what we call neuroplasticity, or how well your brain can adapt to injury or insult. And we can't really predict who's going to have better outcomes than others sometimes, and this is a really great example of that, that even though she had had a significant stroke, her brain was able to really work around that area of injured tissue, and she presented at the time of discharge with no symptoms at all. The last case study we have to show you is a 65-year-old male that had sudden onset altered mental status, vomiting, decreased level of consciousness, dizziness, quadriplegia, and anoscoria, or pupil changes, while standing in the kitchen. Last known well was equivalent to stroke symptom onset at 11:30, which was an hour and 45 minutes prior to arrival at the hospital. The patient had a pretty significant past medical history of coronary artery disease, diabetes, atrial fibrillation, which again increases the patient's risk of clots if not well controlled, high blood pressure, and high cholesterol. When I teach about stroke, I always say, hypertension, hyperlipidemia, and diabetes is like the trifecta for increased stroke risk. All three conditions really injure your blood vessels and really kind of predispose you to having clots, which could present as an acute ischemic stroke. So again, look into what the patient's history is, what medications they're on, because that really can give you a good sensitive indicator of, is this person potentially a stroke, even with symptoms that don't seem consistent with a common stroke syndrome. Medications that they found the patient was on included Pradaxa, which is again a blood thinner, commonly used to manage atrial fibrillation, or AFib. EMS also told the patient is on a new medication that may cause seizures. We weren't really certain as to which medication that could be. So here's the thing. The patient was dispatched as a cardiac or respiratory arrest, again, because of that severe onset of symptoms, right? However, was not neither upon an EMS arrival. What do you mean by that?
Oh, it was initially, you can mention that it was initially dispatched as a cardiac
I
arrest,
see.
but when EMS got there, they actually noticed the patient was not just unresponsive. Well, not
Okay.
just.
I see it. Okay, so this patient was actually dispatched as a cardiac respiratory arrest, but they realized that when EMS came and assessed the patient that it was neither a cardiac or respiratory arrest. The patient was unresponsive. The patient's blood sugar was 233, so this wasn't contributed to hypoglycemia. There wasn't a Cincinnati or Lamb's score performed, and the patient was transported as a priority 1 for being unresponsive to the hospital. So the pre-notification was not stroke-related, it was unresponsive. Thankfully, EMS and the patient were met by the ED team upon arrival. And again, with all of these pretty severe symptoms, the patient ended up being intubated for airway protection. A code stroke was then later activated in the ED, and CT and CTA were completed. Because of the patient's severity of symptoms, the NIH stroke scale we believe to be greater than 30, which indicates a pretty severe stroke. This is the dry head CT that again shows no hemorrhage, which would be one of the key things we'd be concerned about in this kind of patient that presents as unresponsive. It could potentially be a hemorrhage. So a dry head CT very quickly done is very important in this situation. So the CT angiogram was actually pretty hard to differentiate. So what I'm showing you here is a brain MRI. And what you're seeing here is the result of a basilar artery occlusion. So that major artery in the posterior portion of your brain that's perfusing all those key areas of the brain really sustainable for life. And so the clot was so severe that it actually extended up into other areas past the basilar artery. And typically, what you see here with these types of patients, again, is very severe stroke symptoms. Unresponsiveness, dizziness, nausea, vomiting are really key indicators that this was a posterior circulation event. And again, symptoms consistent like this can really result in potentially poor outcomes. Here are references.